Welcome to Live from One Cancer Place. I'm Sarah Kelly. As breakthrough targeted therapies bring new hope to those battling cancer, these therapies can also bring with them dose-limiting toxicities and side effects that can cause discomfort to patients, even threaten their health, which might limit the amount of drug that they can be safely administered. One such side effect is the severe skin rash brought on by EGFR inhibitors like Vectibix and Erbitux. Studies show that 70 to 80% of patients receiving these life-saving drugs were forced to reduce their dose or even stop using the drugs altogether due to the complications from the rash. We hope there is hope on the horizon. Today on Live, our own Dr. Chris Heery, Chief Medical Officer at Arcellx, is joined by Dr. Rona Yaeger, colorectal oncologist from Memorial Sloan Kettering, to discuss the results of the ongoing trial she leads in the fight to make these drugs safer and more effective. I would like to thank our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. And Dr. Chris, it's all yours.
Well, it's my pleasure today to be able to meet Dr. Yaeger. We've never met before. We have some significant overlapping interests. My previous life was working in colorectal cancer, mainly on the immunotherapeutic side of things, but it's always a pleasure to meet somebody doing really interesting work. So could I turn it over to you to just give your introduction of maybe some of your background, how you came to work in this field, and what your main interests are at this point in your career?
Thank you for having me. It's a pleasure to be here. As mentioned, I'm a medical oncologist and I focus on colorectal cancer. I have always been interested in how cancer develops, and in colorectal cancer, there's always been more knowledge because of colonoscopies and study of polyps. And I find understanding those genetic steps most interesting. And my hope is that they give us a hook to maybe prevent things, and definitely at this point to try to treat things in a more targeted way. My research focuses on molecular treatments, so basically taking those genetic steps and trying to match them with treatments. I see patients 1 day a week, and I run clinical trials, but I also have a presence in the lab where we do work with the same drugs that we give to patients, try and understand the effects of the drugs and how to help them work better.
And you are it seems like a New York City lifer. Is that fair from looking? Just my internet search.
It definitely seems like that, but I am not. I've done all my medical training in New York. I grew up in California. I see myself as Californian. I grew up in Los Angeles. I went to Yale for undergrad. My husband is a New Yorker, and I went to NYU for med school, and he stayed at Yale for law school, and I learned about the tri-state area, and I've stayed in New York for all my training since. So I am a little bit, I talk fast like a New Yorker, so people think I am a lifetime New Yorker, but I'm actually from Los Angeles.
That is great. I love when my expectations are spoiled immediately. So this is excellent. So can you talk a little bit about just the background of what we're going to talk about today and sort of how you came to be involved in the project? So, and if you could just maybe a sentence or two before getting into deeper level on what we're going to talk about, just at a high level, what the purpose of the study was and where it came from, and then how you got involved.
Yeah, so I think Sarah summarized it very well, that we have targeted drugs that have side effects, and the drugs that target EGFR have pretty substantial skin effects, and skin effects are noticeable to everyone. There are hard side effects to have, and at the same time that we have these drugs, there are other drugs, specifically the BRAF inhibitors, that have a paradoxical effect in skin. And so we suddenly notice that when we give these drugs with the EGFR antibodies, we can go over kind of some of that rationale, but people's skin effects were better. So the idea here is, can we take advantage and basically create a drug aimed to help the skin effects by using the special properties of another cancer drug, but here is not being used as a cancer drug. It's being used really because of its way of acting in normal cells to oppose the skin effects. So it's actually both drugs are affecting normal tissues, and we're trying to take advantage of a drug that acts very differently to prevent the skin effects. So in some ways, it's a lucky chance that the effects of the side effects actually of another drug are useful here. And this study is looking at, can we kind of harness that and use it in a way that is safe and hopefully allows us to give the EGFR antibodies with less toxicity.
Now, when you explain this to a patient, do you use signaling path, like images of the signaling pathway? Do you ever use it or not? Because obviously, as oncologists, we're kind of trained to think this way. But I wonder, how does that resonate if you try to explain it to a patient? Because I find the slides on the website for the company that does this very, very helpful. But I'm not sure if patients do or not. So I'm interested. How do you explain it?
Some patients want that kind of information. Some patients you can tell they're already coming to you very knowledgeable, and I've drawn diagrams and gone over it with people. And some people want something a little more practical and not looking for diagrams and science and signaling. And in those circumstances, I try to explain, really what's our aim. The initial work was done with combinations. So a lot of it, we were looking at, I would say things like we have dominoes where if you're hitting high up, but there's something blocking it from falling, it hasn't, there's a reason to have a combination. But here, our effect is different. It's the effect in normal tissues. And so it's one thing to say, well, this has an effect in a normal tissue that almost cancels out the effect of the other drug. And some people are satisfied with that. And some people want to understand what's happening. And in those circumstances, I have been known to draw signaling diagrams.
I'm tempted because the purpose of these videos is certainly to speak in lay language as much as we can to help patients. But another part of the purpose of One Cancer Place is also to help bring along patients who want to be those people who help educate people who aren't comfortable with the science. So I'm tempted, and I didn't really run this past anybody, but I'm tempted to show some of these and have you talk through them. Would that be could we share a screen and walk through some of these things and then see if it works? Obviously, we can edit it out if it doesn't, but are you open to doing that?
I'm happy to, yeah.
Yeah, I mean, I'm sure you've done it 1,000 times, so I'm sure it's not too hard. But the reason is that I do think I have some of these slides up. I can pull a couple of them up and we can see how it works. And if it works, great. If it doesn't, we can figure out what to do with this content. But so can we start with what happens when you use an EGFR inhibitor?
So here we have a diagram of kind of like a pathway where we see the EGFR inhibitor in purple. And our interest right here is in the skin. So EGFR is a receptor. This is basically something on the cell surface that's important in the skin. So it's like active in all our skin cells. And so normally it's turning on this program, which we see here, but here it has all these X's on it because we're giving a drug that's blocking it. So our drug is meant to block EGFR in the cancer, but EGFR is important in skin too. So when we give our drug, it blocks all the things that were turned on by EGFR, and that's what's causing the skin changes. So the skin from the drug is very dry. It causes this dry skin, and then it causes a rash because the skin isn't able to the skin isn't able to turn over normally. So that's the issue, that our drug is targeting a protein important in cancer, but also important in the skin. And then when we overlay over that, the BRAF drug, so this is where the reason it's important, I think, to think about like why we care about this signaling. So, you see here that there's like the double line, which is the cell membrane. And you see that exactly. And you see that the EGFR is really the part that touches the outside. It's what's sensing what's going on outside, and it turns on a program inside. And one of the things that it does, exactly, it turns on this RAS, and it turns on genes like BRAF that are what lay the signal downstream. And what this is showing you is BRAF. I think this must be the cancer cell that we're looking at the left. And basically in the cancer cell, you give the BRAF drug and you give the EGFR drug, and you're blocking both the mutation that is telling the cancer to grow and any additional input. And so you're able to block all of these signals that make it to the nucleus that say, hey, it's a good time to divide, it's a good time to grow. And in that sense, that's straightforward. But it's the right-hand side that's our business end today, which is actually in many ways more interesting, because we have a normal tissue, which is acting normally and is turning on EGFR, which is keeping the skin in good shape and fresh. And we are giving a BRAF drug, that the BRAF drug is binding to the normal BRAF. And when it binds to the normal BRAF, it actually, rather than blocking it, because it's not mutated, it actually activates. It causes it more, it makes it more likely, it changes its conformation to be active. And so it is turning on the pathway. So the pathway is on normally, but when we give the EGFR drug, we block it. We had all those red exits that we were blocking the signaling. Now we're giving a drug that's actually in the skin where we don't have the mutation, so it's not turning it off. It actually activates. And so suddenly we have these opposing signals. And that's the whole rationale here. So we have two things. One is we don't want this to happen all the body, because we don't want to be messing with all our body and turning on this program. So we want it to be like a gel that's directly on the skin. And two is we have a drug that's doing the opposite effect in normal tissues. And so we want to take advantage of that.
Yeah, so this is, I'm going to unshare for just 1 second, and then and I just want to come back to some concepts we've discussed in One Cancer Place before. So we've talked about these concepts called pharmacology. Like pharmacology is a general field of study, and pharmacology is an understanding of how drugs go throughout the body and then the effects they have on certain tissues. And what we're describing here is that the kinetics of these drugs are going to be the same throughout the body, because they're kind of small molecules. They're going to distribute very evenly. But dynamically, how they affect how the cancer cell versus the normal cell is the opposite. And that opposite effect allows you to take advantage of something that would happen in the cancer cell a certain way, happening the opposite way in the normal tissue. And I'm going to switch to the next slide so that we can see why that's important. And I'm going to share my screen again. So here we go. And I'll ask you to walk us through this again, Dr. Yaeger. Just why? So what happens? So taking advantage of this, why does it matter?
So what you see here on the left-hand side is what happens when we give the EGFR drug, the Vectibix or the Erbitux or panitumumab or cetuximab. So we give the drug, and it's affecting skin where EGFR is important. And you see that it's blocking all the things that were activated by EGFR, and that's causing the rash in skin. But in the cancer cell, which is turning on EGFR when it shouldn't be, blocking all those things can give us the tumor shrinkage. So we wanted to do that in the cancer cell, but in the skin that needs the EGFR, it's causing problems, and that's causing the rash. So then we get to the other side where we're still giving the EGFR drug. So it's still doing what it needs to do in the cancer cell, but we're adding only to the skin by using a gel. We're adding this BRAF inhibitor. And the BRAF inhibitor binds to what's activated by EGFR and turns it on. So the EGFR inhibitor, the Erbitux or cetuximab, or Vectibix or panitumumab, is blocking these things activated by EGFR, and then suddenly we're adding a drug that stops it. And that drug is actually turning back on the BRAF activation, and that's kind of like one opposing the other. And so you get to neutral, that's the goal at least, to get to neutral where the skin goes back to normal. And so the rash the way the studies are is people go on when they have rash. And so you hope to see the rash resolve. But ideally, the goal would be to give the drugs together and maybe prevent the rash.
All right, so I'm going to pause there. And before we start looking at pictures, because the pictures are pretty amazing, I want to ask, whose idea was this? Because I'm jealous. This is such a great idea. How did this idea come around? What were the steps that went from the inception of this idea to putting it into a clinical trial? And, if you can sort of talk us through from your perspective as an investigator, what needed to be defined in order to try this out, and how long has that process taken? Would also be something I think a lot of patients would love to understand.
So I don't know all the history, but I know, I can tell you, for example, when we first started and we were using the BRAF drugs early 2012, 2013, early in the 2010s, and there's a lot of excitement to suddenly being able to target BRAF. And I was talking to people who are treating melanoma, and they were saying, these drugs are so hard. The patients their skin gets thickened, and they get, on their hands, they get lesions. And I'm like, I don't have any of that. I'm giving it with EGFR antibodies, and patients are doing great. And so we suddenly realized that definitely the effects of the drug are different if you are using it in combination, which became clear that there was an opposing effect, making it easier actually to give it in combination than alone. And so that led to the thought of, well, what's going on in these normal tissues? And I think Tony Ribas, who's a doctor at UCLA, was one of the people who led the idea of, let's make this a topical application. And I think he's one of the founding members of this company. And there's a thought, I think he was thinking also for wound healing, how else does it affect normal tissues? So we tried before, I think this was a commercial company, we tried MSK, just talking amongst ourselves, can we make a cream? And we actually tried for a while, but this is actually being done by a company that I really, like I said, is founded by Dr. Ribas, which is in Israel. This company is like a biotech company that took the BRAF inhibitors that existed as a model to make one that will work in a skin formulation and would be optimized to have this opposing effect. So rather than optimized to block BRAF, it's optimized to turn on the BRAF in the normal tissues. And it's pretty fast when you think about it. It's less than 10 years from the first observations. But there are a lot of observations along the way of these drugs are different, that normally you give chemo and people have side effects. It's the same effect in normal cells. So hair loss is the chemo is affecting what's dividing. So the hair is sensitive, or, diarrhea, the gut needs to get fresh tissue. And so that's being affected. But here suddenly you're seeing, people are having, if they have skin lesions, sunspots, they can increase on these drugs. So it's this is doing something different that is not just the same effect in normal tissues. We started thinking, okay, well, actually, by lucky chance, our patients are doing really well who are getting the combination. Look, this actually has good effects. And you actually can see in melanoma where where encorafenib was developed, which is another BRAF drug, together with a MEK inhibitor, it's given at a higher dose when it's in combination. So that's proof. You can give more drug when you give it together with a drug that acts opposite. So it's the same idea. So this is really we have a need for our colorectal patients to help with the skin effects. And this drug is trying to help with that. But I don't know all the back.
Yeah, no, that was perfect. Actually, a couple of points that I would like to drive home. One, it's very common, I would say, for a primary observation like this being made by physicians to be the thing that leads to an actual effective therapy. It happens more often than we think. I think basic science, these drugs came from basic science, but it actually takes the clinician being hey, I saw this weird thing and I can't quite explain it. And then a bunch of doctors getting together who have scientific training typically and saying, well, maybe it's that this pathway and this pathway are counteracting each other in just the right way. And maybe we should explore that. The other thing I wanted to touch on is that still doesn't happen without a company. And the reason is, it's not Sloan Kettering's job or MD Anderson's job or UCLA's job to make new drugs. They just don't do that. It is their job to come up with these ideas and then find a way to export it so that a company can create the right amount of resources that are needed to manufacture these things in a way that can be delivered more broadly. And I only say that because obviously I'm a little biased. I work for a company now, but I also, we have seen over the last few years that there is a lot of tension from patients and the companies that make these therapies. And sometimes, frankly, it's founded. Sometimes we can see the exact reason why companies can be a huge benefit to patients. And I think those two things can exist at the same time, and you can be right at the same time. But just realize that some of these things would never happen in the absence of a biotech company. It's really important that we understand how this whole system works if we're going to be patients that help other patients understand. And I wanted to point out that even when we think about this being fast, 10 years is fast. This is many, many, many steps from regulatory, manufacturing, all of this stuff to get to this point. And I got to preview some of these slides. I frankly didn't know this study very well, but I'd love to show a couple of images of the patients that have had this therapy because I think it's pretty amazing and I think anyone can understand what the impacts are. So I don't know if these were your patients, but could you just point out what you're seeing as you look at these images, Dr. Yaeger?
Yeah, so you're seeing the typical rash from the EGFR inhibitors, which is often around the nose. It kind of spreads from there, and it's acneiform or pustular, and you can see it's pretty obvious. Like you really don't have your privacy, like getting treatment. People can see it, and this person clearly had a big improvement, and you can see that the rash it's less red, less surface area is involved with the application of the cream, of the gel.
I mean, so this 14-day. I don't think I can imagine, right? If you were walking around with a rash like this on your face, and you were being forced to decide between treating your cancer effectively or getting rid of this rash, there are people who would legitimately choose to get rid of the drug, even if it was working, just because of the discomfort it was causing in their quality of life. Is that fair? Have you seen that happen?
Yeah, I mean, a lot of us use these drugs later because it's hard when your first treatment to have these kinds of side effects. And I think as we keep moving, people accept it because they want it, they need something, but the rash can be really hard. And sometimes, like you heard from Sarah, we take breaks and, we let the skin heal. Yeah, I mean, it's a big issue because everyone sees it too, and yeah.
So here's another example, which is a pretty similar rash. And again, look, you can see, especially here and here on the cheeks, this improving relatively quickly. So really amazing stuff.
And it's kind of a cruel that the people who respond best tend to have the worst rash. So you don't need having a rash alone doesn't mean that someone's going to respond, but that not happen. You kind of need that rash for response. There's a clear positive correlation between presence of rash and response. So it's hard. Someone's doing well in terms of their tumor response, and they have this really tough rash, and they're also very sensitive to the sun. So they can't go out and do the things they want to do because the sun brings out the rash. The skin burns very quickly. And so also in that sense, it's limiting, and people who are responding, would want to obviously continue it for a long time if possible. So it also, it's hard to do something like that for a long time.
Yeah. There are other images around radiation-induced rash, which maybe we could talk about later. But instead of just looking at the images, would it be possible for you? And again, I don't know that going through graphs and charts and things like are in the paper would be all that helpful for this audience, but could you just talk through at a high level what the endpoints were of the study and what you were trying to demonstrate and what the results were?
So the study is like you see, it's basically helping people who already have rash. So people are already on treatment with an EGFR antibody, and they have a rash, which is significant enough to be on study. So that's like involving more than 10% of the skin or affecting their function. So they have a significant rash that's not infected. And so then they go on study where they're putting on the topical therapy on the areas with rash. So on the face, if the chest is involved, on the chest, on the back, and they're being followed weekly. And the goal is to look at the effect after 4 weeks. So at the 28 days, and to see if the two things. One is if the rash appears less severe, like when we look at it as we did, and also to ask people questions in terms of the effect of the rash on their lives and on their function, if that is improved. So those are the things that are being assessed. And then in the ongoing clinical trial is to see if they're able to continue treatment, like are they able to continue the EGFR inhibitor without having to stop it when they're on this therapy. But the ongoing trial is, unlike here, where they're looking at what's the right dose, what's the effect, is looking at this versus a placebo to see, is this really helping?
And do you know what is the expected timeline for the results to be available?
I think the study is expected to enroll over the next year, maybe year to 2 years. And then the results are pretty quick because this is a quick readout. It's looking at the effect after 4 weeks of treatment with a follow-up of another kind of 4 weeks. So it's not a long term. It's looking at what's the immediate effect of this drug.
Now, I don't know if this is out of bounds, so please just say so. But is it possible that you could actually see improved things like median progression-free survival or improved overall survival as a result of controlling toxicity in this way? And is that being captured in the study?
I think that's the goal, is that I guess there are two goals. Of course, the first goal is to help with the skin. But the second goal is help with the skin so that you can continue on treatment. And it's being followed once patients come on when they're already on therapy, right? They already have rash, and it's being followed how long they stay on treatment, whether they discontinue treatment, and if they discontinue it for skin effects, or if they discontinue it because it just stopped working. And the EGFR antibodies are becoming more important because initially, so this feeds in also to the rest of my work. So initially they were used more broadly, but now we know where they work. So they're really being used for a very small subset now of patients with colorectal cancer. But they're being used as partners now with lots of drugs. And that's how this came about, because the EGFR antibodies were given with BRAF inhibitors, where the patient has a BRAF mutation and they need the BRAF drug, but the EGFR antibody helps it work better. It blocks all that activation of tumor growth as a joint kind of together. So now they're being combined with KRAS inhibitors for patients who have KRAS G12C mutated colorectal cancer. So it used to be, as we've understood how to use these drugs, that's a small part of the pie where they're useful, but actually now it's becoming a partner for many new drugs. And so in terms of will this help people be on treatment longer? It may help both for the EGFR antibodies and also for drugs that would be given together with them. And so it is possible that it can help other, therapies that use this as one component.
Yeah. It's very exciting. So I imagine there are patients out there who might be watching this at some point and saying, well, how can I get access to this? How could I be on the study? Is the best method to go through clinicaltrials.gov, or is there another method you'd recommend for people?
Yeah, I think that's good. I think it's open in, like 5 or 6 sites in the US. I take that back. I think it's open in, I wrote down 15 sites in the US, but it's like major academic medical centers. So if you look, you can see what's near you in terms of academic medical centers, and it's also open in Israel. So to see what's available, and it's not, like we said, it's not a long course of treatment. It's really getting the skin application, and they allow telehealth for some of the visits. So it's if someone's at a distance and they can do it for a few weeks to come back and forth to a center that's participating, it may still be feasible.
Great. Just for, I'm going to say this, and maybe in like the editing process, we could put this on the screen. The clinicaltrials.gov identifier is NCT 047596664. I'm going to flash this up really quickly as I'll share it on the screen so that if people want, they can screenshot this and find the same thing. This is the study, right?
Mm-hmm. Yep.
And so the study locations you can find by scrolling down and clicking here. Maybe one day we could just do a clinicaltrials.gov one cancer place, just navigating clinicaltrials.gov, brainstorming in real time here. But so these are the sites, and what is recommended is that you contact the either the individual sites if one's closest to you, or there's a contact number, a central call number as well. So you can try either method. Great. So what have we not covered that we should talk about with regard to what might happen next with this type of approach? Do you think for other inhibitor agents where you have toxicities, there might be similar ideas floating out there, and or for this pathway specifically, do you foresee any other future uses?
I think this is kind of a unique application. I think there's a new generation of drugs, of cancer drugs that are very specific, like the BRAF drugs that work only for the BRAF V600 mutants or the KRAS G12C. And some of them are specific in that they don't work in other cells, like the KRAS G12C, but some of them are specific, like here, where they work one way in that special scenario, and then they work another way in other tissues. That's, I think, a special effect here that gave the BRAF drugs what we call a therapeutic index, which is that there's a range of doses that you can tolerate before you see side effects, because the effect of the drug is really so narrow against the cancer. And so here in the BRAF drug, the therapeutic is affected by the effect that's paradoxical, like say, that is the opposite effect in normal tissues, which you don't see. I don't think you see so often. So I think it's a unique effect here. There may be other applications. This is a very natural one that came because the drugs were being combined anyway for some patients. And then we're seeing, hey, the rash got a lot better. I mean, these pictures are dramatic, but on the flip side, I was treating people and there was no rash because they were able to get doses of both drugs in. And, you first meet with people and you're saying, I'm going to give you a drug that causes rash, and I'm going to give you another drug that causes rash, and they cause different rashes. And then it's nice after a few patients to be like, actually, it seems that they cancel each other out. So you'll have a mild rash or not much, because even though both cause rash, they are acting in the opposite way. And it came from that.
Yeah, that's great. Do you, I'm trying to think through, is there a reason why this wouldn't work with, say, erlotinib or another small molecule EGFR inhibitor?
It should work. The antibodies, I think, have more rash and less diarrhea as a dose-limiting effect. I think some of the side effects are similar, but they're kind of spectrum and their frequency is a little different. So the rash is like the most limiting effect, is often the limiting effect for the EGFR antibodies. But if you look at the information for this drug, the idea is that it could be used for lung cancer for the EGFR, like erlotinib or osimertinib, some of those TKIs as well. But I don't think the rash there is often as significant. And they probably have a different place, those drugs. So in colorectal, we are blocking a normal receptor that basically the cancer is just turning on. While in lung cancer, that receptor becomes mutated, and that's how it's being turned on. So the drugs are a little different, and that's why we use slightly different drugs, because the erlotinib, those type of drugs seem to work better on the active receptor, while we have a receptor that's normal, that's probably being activated by its surrounding environment that's turning it on. So I think that probably leads to a slightly different spectrum of the effects that you see.
Yeah. I'm glad you made that point. I wanted to make the same point, which is that when we go back, if you want to rewind back to when we were showing the images, we're talking about something that controls that signaling pathway from the surface of the cell, those receptors, and sort of blocking that receptor completely, which is what the antibodies do, versus the other molecules that we're talking about are small molecules, and they only work, or should only work, when that receptor is modified through a mutation and fits into that mutated version of the receptor. And so because of that, it shouldn't be as able to interact with the normal receptor. We do see it sometimes with those molecules, but that's probably, again, comes down to how specific that molecule is for that exact part of the receptor, and how much of a dose you have to give to see the effect. Because we are, one of our goals for this series is to help people understand some of these concepts. I also wanted to just mention that when Dr. Yaeger said earlier that when EGFR monoclonal antibodies work best, those are the patients who tend to have the worst rash. And or vice versa. The patients with the rash tend to have the best outcomes. That again comes back to the same pharmacologic principles that we were talking about. So that means that you're probably saturating those receptors really well with the dose that you're giving that patient, but you're saturating it everywhere in the body, which is why you're seeing the rash. So those concepts, I think the more and more we hear about them, people can understand them a little bit better. But remember, when we send a drug in to treat a cancer, we have to deal with wherever that drug goes in the body. And that's kind of, I just wanted to highlight that point because it's a really great point. And sometimes people don't kind of get why that would be true, but it's just because that means that we're giving the right dose for the cancer, but it's also affecting the other parts of the body. Well, I think we're at a good spot to open up to see if there are any questions. I already covered one of the questions somebody asked, which is how can you get on the study? So that was an amazing overview of, I'm sure, 10 to 15 years of science and observations that have led to where we are today. And I think we can all look optimistically about where this could take us, because I do believe that this should affect, at least for some patients, how long they can stay on these drugs and therefore control their tumor growth. And that's probably the most exciting thing. Obviously, the quality of life matters a ton as well here. So let's open it up and see if there are any questions from those who have joined us. So we have one in the chat, so I'll read it and try not to butcher it as I'm reading it in real time. But so one of the questions is, this person is a NED stage 4 colorectal cancer patient, successfully had resection of the colon, lymph nodes, and liver mets, and a second round of adjuvant chemotherapy, Folfox and Vectibix. Developed a rash and was icing his feet in the hope of reducing the effects of neuropathy from therapy. And within hours of completion of each infusion, developed a fever that was 6 degrees above normal. And then at first wondered, and then had chills as well, wondered if the body temperature was anything to do with the icing, or whether the Vectibix might have been causing the fevers and chills. Could you comment on just sort of the why some patients who get monoclonal antibodies occasionally get these fevers and chills?
I guess, first of all, it's great that this person sounds like he's doing very well and is done with treatment. Just like Dr. Heery mentioned, people can have reactions to these medications. These are medications that have been developed to be kind of going after a target. So they are antibodies, and the initial antibodies, the cetuximab or Erbitux, is actually what we call chimeric. It's part mouse, part human. And so when our body sees it, sometimes it reacts to the part that is not human. And that can lead to kind of allergic response. And that can be a fever, that can be being red, and it can be more severe, feeling short of breath. It's less common with Vectibix, which is a fully human antibody, but it's still a foreign product and people can have a reaction to it. Having a fever with each treatment seems to suggest some reaction. So I would imagine it's a reaction to drug rather than effect of the icing. It sounds like this person luckily is done with treatment, and so doesn't really have to worry right now. But if someone was in that situation, their doctors might slow the rate of infusion, may give pre-medications to prevent a reaction, and so try to be proactive to prevent the fever for the next treatment.
I mean, I think the experience of any doctor who's given monoclonal antibodies is that a lot of work is done to try to reduce these risks. But it's a very common theme that monoclonal antibodies, that people can have low grade in what we call sort of infusion reactions after them. And usually temporary, usually can be controlled with, Tylenol or Benadryl or both, but sometimes they can be a little bit tougher to manage. So I agree. It's great you got through it. I don't think it was from the icing. I can say that. I think it was probably from the antibody. So if that was your question, I'm not totally sure. But then the other question that's in the chat now is, this is a very interesting question. I actually would love to hear your opinion on this. That this patient had a rash that had mild to severe intensity. And then over time, that rash has gotten less severe without changing dose. Should the patient be worried that the dose is not sufficient, and should they consider increasing dose as the rash is diminishing with subsequent rounds of therapy?
So the short answer is no, that the rash is dynamic. It's most severe kind of early on. Like a week or two in, the rash usually starts to develop and peaks after 2 or 3 weeks. For some people, it gets better and then kind of has intermittent periods where it gets worse. And it's always quite significant. And for some people, the rash improves. And it's a sign of the change in the way it's affecting the skin. But in my experience, when the rash improves, the skin is still quite dry. So the skin is still quite affected by drug, even though you actually don't have a visible rash as much. But it's not a straight marker to in terms of how much drug you need and how well is it working. It's the effect of the drug on the skin changes over time. So I wouldn't take that to say, oh, this is no longer giving me the same dose. It's not. And if you've been on it a long time, it's probably a sign that it's worked and the tumor continues to respond. These drugs actually work pretty well, that actually, even when you reduce the dose, you can continue to block the pathway quite well. So I think that it's a good thing that the rash is better, and I'm glad that it's a little easier to continue on the treatment.
Another great follow-up to that is then, do you think that a drug like the one we've been discussing, a topical cream, could still be a benefit even if the rash has improved a bit? For a patient that has ongoing rash, albeit more mild than it was previously. And do you have plans to evaluate that, I guess, prospectively in the future?
Yeah, I think so. I agree. I think right now the plan is to say, in people who have a significant rash, does this help? But of course, the goal would be obviously to have the medication up front and to prevent that significant rash. And I look back again to the example when I was treating patients with the combination treatment and the rash wasn't so severe. And I would say to patients, this is what we give for preventative for the rash, but this is for symptoms. It's not for the cancer treatment, but it's good that you have it. And, some people want to start, like we often give antibiotics at start, and that's that's our standard. At MSK, we often give antibiotics, and I tell the patients, if you have no rash, you can stop the antibiotics. They can cause stomach upset. You might not need it. So similarly, if you had a cream that you can use that we know would we know has kind of an on-target effect. We've shown that it improves the rash. To have that at the first sign of rash, to be able to apply it, and then if the rash improves, to be able to stop, I think would be very useful. And there's data for other creams, but the problem is the data is not so strong. We don't have a great way to treat the rash. So some of the data, like of giving steroids, maybe it helps, but it doesn't seem to help so much, and it's not clear. And so there's need for something better, and there's nothing that is actually approved as an FDA approval just for the rash. So the hope is by showing people who have the rash are improving, we can say this drug is acting on the level of this rash and improving that, and then we can think about for patients the best way to incorporate it. I think most of us wouldn't want to wait till the rash, like you saw those pictures, we wouldn't want to wait for it to be so severe to start using something to help.
Makes sense. It makes sense. I also agree. It's really exciting to have something potentially on the horizon that could help, and I would hope that this is something that could move relatively quickly to an approval from just the images and the data that are available. It seems like a relatively low downside. I don't really see much downside, and it seems like there's a huge potential upside for patients. So that's awesome. I'll just do one more check to see if there are any other questions before maybe we move to the wrap-up portion. And if not, I'll do just a summary of what I think we're seeing here, and then I'd love to hand it over to you, Dr. Yaeger, to just with any final comments. But it's a little bit unusual in my experience to see a therapy developed that is primarily intended to improve the patient's quality of life. And I'll say that with maybe from a little bit of the pessimistic standpoint, that oftentimes there isn't an obvious way for a company to make enough money to do this in a way that it makes sense. And so sometimes these things never get started. So I would just say this is extremely exciting to see that a company has been sort of built around this. And I genuinely hope that they are appropriately rewarded for doing something that's going to be really helpful for a lot of patients. And what I mean by that is, I actually think this could be the type of drug that a lot of people buy and a lot of people use, and it is helpful. So I'd like to, congratulate everyone who's been involved. Obviously, I can't know everyone's name who's been involved in doing this, and whose original idea and observation. It's probably a lot of people. But I think it's a great example of how it takes a lot of people and a lot of time to take something from an observation to really making a difference in patients' lives. And it's just really exciting. I'm really impressed by what we've seen and heard today. And I want to thank you, Dr. Yaeger, for walking us through it in such a easy to understand way. Even rolling with me, just throwing the slides up on the screen. So thanks for doing that. I imagine that people who tune in and watch this video will mostly understand what you mean, even if they don't have an understanding of cell signaling biology. And they can rewind it and watch it again if they need to hear it 5 more times, because we both talk a little bit quickly sometimes. So just go to 0.75 speed on YouTube. Maybe that'll help. So, but anyway, thank you again for joining us, taking time out of I'm sure your very busy week. And if there's anything you'd like to add to finish off, we'd appreciate it. And just again, thank you for spending the time with us.
Thank you very much. Thank you for having me. I think this is really a great forum, and I'm glad to be part of it.
That was great. I just want to say thank you so much, Dr. Yaeger and Dr. Heery. You guys always do such a fantastic job, particularly explaining it so us patients can really get a good understanding of it. And I really appreciate your time and efforts.
That was fun. I actually had not seen this stuff before. I am wondering why you wouldn't just use a systemic BRAF inhibitor.
So the BRAF, we don't want to have the systemic effects. So the same way it like turns things on in the skin, it can turn things on and other tissues. So they're associated with like melanoma, patients who've had like maybe first steps that has been associated with pancreas, like a BRAF V600 pancreas cancer. Someone was on BRAF and developed a pancreas tumor that had a RAS mutation. So it's activating all normal tissues. And that's the flip side. Like if someone had a really superficial melanoma, this would probably be great treatment. But if someone applied it forever, it probably is not good for the skin because it's fine because you're opposing it. But if you're giving it alone, you're turning on that pathway. And so you kind of want it. So it's the bad systemic that actually opened the door to thinking of this as if we give this so local, it could be really good. Yeah.
What about an oral formulation that could get past the stomach, though, to affect the endothelial lining of like the colon, if somebody has colitis from EGFR monoclonal? Is that possible?
I think you can do it. I think theoretically, it should be effective. It's the same idea. I mean, it's doing the opposite of all these things that are turning off the pathway. Yeah.
I had a really interesting experience. I took cetuximab with Braftovi because I have the BRAF mutation, and I didn't really have a bad rash while I was taking it. But when I stopped both drugs, that's when I got the rash. Yeah. And so your explanation today really explained why that happened, because the Braftovi was stopping the rash, but I guess I still had the cetuximab in my system for a while. And so for about a month after I stopped both therapies, I had the really horrible rash.
You're exactly right, because the antibody has a long half-life and the Braftovi is like a small molecule, has a short half-life. So you stop the Braftovi and the cetuximab is like just unopposed. And that's you said it perfectly. But it's all these little insights which kind of suddenly showed us, oh, look, these drugs are interacting. But you said it exactly right. Yeah.
Thank you.
Well, with that, I think I can hand it back over, Sarah.
Thank you. Today, I would like to thank Lutris Pharma for their efforts in improving anti-cancer therapy effectiveness, and thanks to all of our patients who joined us today. Special thanks to our experts, Dr. Chris Heery and Dr. Rona Yaeger. And again, thanks to our founding partner, Seagen, and our supporting partners, Colorectal Cancer Alliance, Natera, Colon Cancer Coalition, and Mirati Therapeutics. We look forward to seeing you next time on Live at One Cancer Place.